Today's.
Yes, over to ma'am.
Yes, sir. From morning onwards, I was catching with the passenger train to your suite. So, but I think you were covered again with the from starting that how the differentiation between upper cervical and lower cervical, how we can give the thrust in the positioning itself by taking the barrier of the flexion and lateral flexion in the positioning of the flexion, then taking the barrier according to the C0, C1, where with the coupled motion direction, and where for the lower cervical also, that how we can reach with the barrier and we can give the, in a very soothing way, we can give the thrust. There is a no hurdle in between when we take the movement in very according to physiological and anatomical barrier, we keep the joint position, and with the hand movement, how we block the below level, and then after that with the articular pillar, how we can understand the movement, and then we can give the thrust safely, so it will never worsen the patient symptom. And as well as with the thoracic spine, the blocking the thoracic spine or the scapula with the anterior or posterior force, that is also very important to treat the cervical spine. And as in now session that you were, how the lumbopelvic differentiation is very very important when we are going to see the patient, that patient is having a pain in the hip problem is there, or the in the lower extremity the problem is there. So differentiation with the lumbar spine is always very important, either with the lumbopelvic differentiation or with the flexion in the standing or the sitting position. How we are finger placement is very important there. How we check that either the sacrum is moving with the PSIS joint and the both are moving. So how we can differentiate between the sacroiliac dysfunction as well as the iliosacrum dysfunction. These are very important things whenever we are going to treat the lower extremity. So differentiation is always a very, very important for that sacroiliac and iliosacral according to their joint movement. Then we can move towards the lower extremity kinetic and the kinematic chain, where the influence of the hip on the knee and knee on the foot is explained, and as well as practical demonstration shown by you on the Dr. Muzammil, that how hip can influence the knee and the knee can influence the foot by keeping the movement of the hip external rotation versus internal rotation. Then also valgus and varus force of knee plays a very major role, as well as the supination and pronation of the foot is influenced by the dorsiflexion and the plantar flexion. So these are the things also very, very important when the subject is doing the movement. So how we check the hip is externally rotated or internally rotated, and then we check with the lumbar spine movement is also either the patient is having the pain is aggravating or relief with the lumbar spine movement. So how we can check the influence of lumbar spine on the lower extremity or kinetic and kinematic through the functional movement. So there we can check either the need of the articular treatment is there by giving the external need of external rotation or internal rotation, where we can utilize with the chiroactivator tool, or is there is a need of the myofascial component where we have to train the abductor adductor, or maybe the need of flexion is restricted or the extension is restricted, where we can keep the position itself in the neural, like you were showing in the sciatic nerve position or the femoral nerve position itself. We can keep the patient by keeping the leg position where the extension is in the need or the flexion is in the need. According to that, we can give the activator tool in the flexion position for according to the convex concave rule. That is also a very, very important thing where we are going to give the force, or for the abductor or for the adductor. So these are the things I think according to the lower extremity kinetic kinematic chain, where the laxate approach of AMPT is always the best way to understand about these mechanism of all these three parts. Or if we are going to treat any athlete person, the sportsman, the sports person, whom always we check the lower extremity dysfunction. So in that also we can see. And as I was telling you that I from last 4 days I was treating the one fitness trainer. She is a in the cult fit. She is a fitness trainer. So she was having a sacral dysfunction, unilateral sacral dysfunction while doing the exercise in the gym. So her sacrum is stuck in a unilateral position. So same that as you were explaining, I have checked with the functional movement testing. So I found that there is a unilateral sacral dysfunction. So there I have used this chiroactivator tool that I have given on that particular where the sacrum was in the stuck in the position. So that I have given the inferior force towards the plinth. So that has corrected her sacrum on the right place. So this is the way, because she is an athlete, so she can bear, I can provoke her symptoms also, pain also. So I have worked with the functional as our FNST goal. I have checked in all the position. Then I got the barrier that I have to fix this sacrum joint. So that I fixed. And after a fourth sitting, she is completely fine. And today she did her legs workout also. And now she is very comfortable. So this is the way, as a pathomechanics or biomechanics, we get the right way to treat our patient as a functional mode, as a in the functional way, so that they can get their functional activity in a back to their work. So thank you so much, sir, and explaining about this hip mechanism, which is very, very important when we talk about the lower extremity, and the influence of the lumbar spine. That is also as a referral or as a movement testing, either the static or the dynamic, both we have to do the movement testing, and their observation with the posture, that is also important. And as well as the pain based mechanism, which you have explained in the morning session, that how it is very important to treat their patient according to the 5 mechanism, the pain based mechanism with the cognitive, central, nociceptive, nociplastic, as well as the autonomic, the sympathetic. So these are also very, very important part of our as a patient centered approach, so that we can reach that what is the basic problem in either the physiological problem is there or pathological problem is there, or maybe the patient is having a problem related to their central sensitization. So we can match all the symptoms. According to that, we plan our treatment. So till morning to now, we are, I will say that we have get a very good, the quality information from your side, so that we can recollect all our past courses, either the lumbar spine, thoracic spine, cervical spine course. In that you have already explained in detail all the mechanism, all the dysfunction related to cervical, thoracic, and the lumbar, and as well as FNST or our pain-based mechanism course. So these are the best way to understand the patient function as well as the dysfunction, and then we can correct it. So thank you so much, sir. And that last in which you have shown the functional leg length discrepancy, that was a very, very, I will say, the best part of today's session, that in this, by keeping the patient in a functional mode, also we can check how the plantar flexion is giving the leg length. So how we can check it in that functional position itself, the functional leg length discrepancy, and then we can treat it that in a functional mode only. So thank you so much, sir. And really the participants who are sitting there, they were enjoying. I saw their faces, how much they were happy when you were with the circle movement, you were explaining the movement, how we feel the with the hand placement with the on the articular pillar, or how we can feel anterior and posterior, the joints placement. Then we can give our thrust manipulation. So thank you so much, sir. Yes, sir. Ji, sir.
So we'll resume again with the lumbar spine and go ahead with the manipulation and adjustment techniques.
Yes, sir.
And then we come back to the extremity post lunch.
Yes, sir.
Right.